Any difference?
I know,
Tight
sir.
range.
They have studied
Only
the time in range, sir. Whatever studies I have analyzed, they have studied only the time in range, not the TITR.
similar, but there is a difference with reference to TITR. That is tight range. Tight range. It's quotes over.
Okay.
Thank you very much.
Thank you,
We'll
sir.
take up the question at the end.
Thank you, sir.
And all, at the outset, I would like to thank Dr. Balamurugan sir and Dr. Rajendran sir and other scientific committee panel for giving me this opportunity. So I am going to give an overview about small molecules in diabetes therapy. We all know the ominous octet of type 2 diabetes, that is pathophysiology of diabetes involves various target organs. Even though we have so many drugs, we need more drugs to control the glycemia. Not only control the glycemia, we need more benefits, especially in terms of cardiovascular, renal and other organ benefits without any complications. So for that, one of the innovations are small molecules. What are the small molecules? What is the difference between small molecules and other biologicals? So the small molecules are low molecular weight compounds which is less than 1 kilodalton size. So this is synthesized through the chemical processes. Whenever the molecular size is more, which the structure will be complex and the molecular mass and degree of complexity will be more, so it leads to the more complex and also the stability, everything will be changed. So the key differences between the small molecules and biologicals, the size less than 1 kilodalton and the biologics more than 5 kilodalton. The structure of the small molecules are very simple, well defined through the chemical synthesis. Typically it avoids the intravenous admission. Typically all the small molecules are oral administration. Stability is generally stable. So whenever we take the biologics, it is a living cells system, production through the living cell systems. Usually it is in injectables, so it is temperature sensitive. So the advantage of small molecules are very targeted therapy without any complications. So the advantages of small molecules, the oral bioavailability, it enhances the patient compliance, especially through the oral administrations, avoid the injections. So we can improve the adherence to the medications. The manufacturing and cost efficiency, it is scalable through the chemical synthesis process, low production cost compared to the biologics, especially whenever needs it, like diabetic management therapy, we need more amount of production. So better tissue penetration, especially it is a small molecular size, it allows the penetration into the tissues and cells, so we can reach the target and access the target which is not accessible by the biologics. And also it's a low immune risk and antibody formations compared to the biologics, and also the formulation flexibility. We can give a combination therapies and controlled release preparations to achieve a good control. So what are the disadvantages? So it can cause us off-target effects, especially it has a low specificities compared to biologics, which can lead to unintended interactions with other molecular targets, which causes some fewer complications like gastrointestinal disturbances, hypoglycemia, drug-to-drug interactions, especially cytochrome P450 system involvement, and also it has a shorter half-life, so we need more and more drugs as compared to biologics, like weekly once or monthly once regimes. We have the limited biologic complexity because it cannot mimic the three-dimensional structure and functions of protein, so the efficacy is limited. So already we have FDA approved small molecules, that is SGLT2 inhibitors, already approved the empagliflozin, DAPA, CANA and ER2, and also the bexagliflozin approved in 2023. And there are the sotagliflozin, which is a dual SGLT2 and SGLT1 inhibitor. The DPP4 inhibitors are approved by the FDA are sitagliptin, linagliptin, Saxa and alogliptin, thiazolidinones, pio and rosiglitazone. These are the newer oral small molecule anti-diabetic agents. That is, one is the oral GLP receptor 1 agonist semaglutide and GPR4 agonist, that is FFA1 receptor agonist, free fatty acid 1 receptor agonist, and bile acid sequestrants, that is colesevelam. So So which is the advantage of controlling the glucose, the cholesterols also. So another small molecule oral GLP-1 receptor agonists are, these three are, the drugs are approved by the FDA, danuglipron, orforglipron, aniglipron. These studies showed that not only it controls the sugars, it also controls the weight. So it is an added advantage. We can give an oral, not as injections. So other newer drugs like incretin-based therapy, we can take an dual and triple agonists, that is GIP, GIP and GLP-1, GIP and GLP-1, GLP-1 and glucagon, GIP, GLP-1 and glucagon. So there are drugs, and another class of drugs are glucokinase activators, which is enhance the glucose phosphorylation in liver, pancreas and increase the insulin secretion and hepatic glucose uptake, that is dorsagliatin. And acetyl-CoA carboxylase inhibitors that inhibit the acetyl-CoA enzymes and reducing the fatty acid synthesis and increase the fatty acid oxidation and improve the insulin sensitivity. Next class of drugs are situvin activators, that is activate the NAD dependent deacetylases, that is mimicking the caloric restriction effect, improves the mitochondrial function and insulin sensitivity. The next class is AMPK activators, activated AMP activated protein kinase, which is the cellular energy sensor that regulates the glucose and lipid metabolism. The next class of drugs are FGF21 analogs or mimetics, that is mimic fibroblast growth factor 21 that improves the insulin sensitivity, glucose uptake and also act on the lipid metabolism. There are another technologies, that is nanotechnology and small molecule delivery, that is PLGA coated nano insulins, that is coated for oral or patch delivery and implant delivery, which reduce the required dose for efficacy and improved pharmacokinetics. There are ongoing trials for encapsulated insulin and GLP-1 mimics. It is potential for once a day or long-acting oral regimens. It is a newer therapy or smart nanotech insulin pumps. And another oral insulin on non-peptide insulin mimetics, which is a nanocarrier based oral insulin. Clinical trials initiated in 2025. It is liver targeted delivery for higher efficacy and less hypoglycemia. Insulin mimetics, that is non-peptide drugs activating the insulin receptors. New chocolate capsule insulin delivery explored in primates, that is significant future promise in type 1 diabetes and type 2 diabetes. What is the future? We have seen all the class of drugs. What is the future? So as the ADA and ESDA says that each diabetic patient need a personalized diabetes management. So we need to have a personalized diabetes medicine in the form of pharmacogenomics. Identify the genomic variant that predicts the drug response in individual patients' efficacy and adverse effect to guide the optimal therapy selection, and also patient stratification. We have to classify the patients into subgroups based on the pathophysiological mechanisms, comorbidities and biomarkers we have to tailor according to. There are rational combination therapies. We have to combine therapy we should give to achieve the therapeutic target. And also emerging approach like drug repurposing. Identify the existing approval small molecules with the potential anti-diabetic effects through the computational screening and mechanistic studies. And also we would to include the AI and machine learning in drug discovery. So the conclusion, small molecule anti-diabetic therapy drugs are continue to evolve with an improved efficacy, safety profile and novel mechanisms, actions which is beyond the glycemic control alone. So we have already approved drugs, SGLT2 inhibitors, oral GLP-1 receptor agonists, demonstrated that which achieves not only glycemic control and also cardiorenal protection, weight management. There are few unmet needs. So beta cell preservation and regeneration remain a critical target for future small molecule development to address the progressive nature of the diabetes. And also personalized medicine approaches are needed to optimize the therapy based on the individual patient characteristics, comorbidities and genetic factors. So the future is multi-target, small molecules and rational combination therapies will likely dominate the future development to address the multifactorial nature of the disease. So these are my references. Thank you very much for the patience listening.
Thank you, Dr. Ramesh, for taking all of us. So, orally available, non-expensive, non-peptide molecules, small molecules, currently under clinical evaluation.
Yes.
You have started with ominous octet, Western Banting lecture, and Dr. DiFranco, he made a presentation on that. Now, recently he has passed one comment. Apart from 8 factors, yet another factor is hypercortisolism, and he is going to rename it as noxious 9 from ominous octet.
Yes.
You have started with ominous octet, Western Banting lecture, and Dr. DiFranco, he made a presentation on that. Now, recently he has passed one comment. Apart from 8 factors, yet another factor is hypercortisolism, and he is going to rename it as noxious 9 from ominous octet. And this was also highlighted in one of the recent ADA presentation, where Dr. John Booth as well as Vivian Fonseca, they made a presentation on concept catalyst study. They have established hypercortisolism as one of the risk factors for hyperglycemia in patient with the type 2. Nice presentation. Now I invite all the speakers onto the stage so that now the forum is open for discussion. PK pathway as well as phosphoinositol, AKT pathways, insulin-mediated glucose uptake.
Actually, adiponectin.
But you have clearly made a mention. Not only acts through the AMPK, but AKT pathway, ERK pathway, as well as gamma-mediated effect. Whereas insulin binds only with insulin receptor. So phosphoinositol mediated action. So glucose uptake. So if we come across adiponectin receptor analog, what will be the chance of hypoglycemia?
Sir, actually, these analogs are in the preclinical stage, sir. So only clinical trials can tell us more about the adiponectin receptor analogs and efficacy and all those side effects. Everything can be studied in that only, sir.
Okay, no problem. Now the forum is open for discussion. So these are all very latest and important topics. All the speakers, they have covered this particular topic in an excellent way, and in fact, we learned some of the newer points. Starting from Dr. Surendran up to Dr. Ramesh. The speakers, they have delivered the presentation in an easily understandable way, and you all have understood the concept behind it. So I thank the organizing committee member for having invited to moderate this session. I also thank my co-chair, Dr. Ranjit, who is a senior physician and diabetologist from Nagarjuil.
Thank you, Dr. Shanmugar. Appreciate the great talks by all the speakers today, and you actually discussed quite a bit about the future of management of this complex disease of diabetes as well as metabolic derangements. And all 4 of you had handled their own topics in a very nice, understandable way. Congratulations to all of you. Thank you very much.